you so much, Mark, for being here. You currently serve as the founding director of the Duke Margolis Center for Health Policy at Duke University, and you are focused there on developing and applying health policy solutions to improve health, health equity, and the value of healthcare with a local to a global focus. What is that pebble in your shoe, the one problem that you grapple with that if you had an unlimited budget and unlimited staff and time, that you would really like to solve?
Well, Patty, first, thanks for the opportunity to be with you and all the participants in this great webinar series. I'm glad to be a part of it. And I'd like to maybe take that as a topic that we'll keep coming back to today. Probably if there is one common denominator for all of our work, it's the big gap that persists between what our medical technologies and know-how are capable of and what we actually seem to be delivering in practice. And that's everything from, like in COVID, we had the best diagnostics, the best treatments, the best vaccines, and the most of them in the world. Still had outcomes that were not very good relative to other high-income countries. And today we're still struggling with lots of new diagnostics that enable earlier, more effective intervention for a wide range of conditions, better treatments for those conditions than ever before. And yet our population health outcomes have been getting worse, and we still see these persistent disparities in healthcare, and our healthcare costs are too high. So it's that's a lot packed in there, but it means that we've been pretty busy at the Duke Margolis Center on trying to identify and support and advance innovative ideas for dealing with these problems and the policies that can support them.
Now, one thing that stands out to me is at Duke Margolis, you have assembled a very diverse team. Can you tell our listeners a little bit about the diversity in skill set and background that you bring to the table there?
Yeah, I mean, Patty, my own background from spending a lot of time in government is that these healthcare reform problems require maybe not all hands on deck, but certainly all fresh perspectives, all stakeholder perspectives possible. So when we were setting up the Duke Margolis Center, Duke was willing to take on a kind of different approach. So we focus on health policy and health reform, but we are explicitly set up as a university-wide program. So I report to our university's provost and also the head of the chancellor for our health system. And our faculty are distributed among all of the different schools and departments at Duke because, frankly, their perspectives are really important for a lot of the challenging cross-cutting issues that we work on around how to improve biomedical innovation and bring the benefits to people more effectively, and how to redesign healthcare so it's better at prevention and person-centered care. So we have affiliated faculty in business, law, arts and sciences, engineering, medicine, obviously nursing, and public policy. But we really try to set up the program to support interdisciplinary research. And we also have a big emphasis on the applied part of research. So not just coming up with the ideas, but making sure we can translate them into practice. So we have a lot of our researchers and staff who are based in Washington, D.C. office, where they can work more closely with federal agencies, Congress, other groups that tend to convene there. And we have faculty and researchers who are working very closely with the state of North Carolina, with other states on healthcare reform issues at that level too.
So let's pick up a little bit on those two words that stood out to me, applied as well as your relationships in Washington, D.C. You spent some time there doing some important work at the FDA and at CMS. And recently, you've been quite involved in the Inflation Reduction Act, certainly poised to be one of the most revolutionary changes to the U.S. drug pricing in decades. It's going to change how Medicare Part B and D work, and hand in Part D. And Tell me what you think is going to be the impact that specifically on real world evidence, since CMS has said that they have quite an interest in incorporating this as essential evidence. What should our industry be preparing for methodologically, operationally, in terms of real world evidence requirements and application?
Well, CMS has certainly emphasized in these, I should say, and emphasize on my end that we're in the early days of implementation of the Inflation Reduction Act. CMS is still in the process of just issuing guidance for how they're going to implement it. They have an impossibly tight timeline for implementing many of these provisions. When we set up Medicare Part D in the Medicare Modernization Act, we had a couple of years to go from legislation to implementation. Even that was really hard to get all the details right, engage the public, and so forth. This is even more compressed than that. So there's still more guidance to come out from CMS. There also are lawsuits out there, as you know, and things are going to change before we settle down and really see how the law will have, what kind of effects the law will have, and how any undesired consequences might be addressed. So maybe we can come back to some of those issues too. But on real world evidence in particular, CMS has emphasized that they view the law as really being a means of advancing its use, in contrast to other price negotiation or regulatory price regulation approaches that other countries around the world have implemented. This is new pricing steps that come in 9 years to 13 years after a drug has been on the market. And CMS, in its initial guidance, highlighted that they're really going to be focusing first and foremost on the evidence supporting that a drug has a differential impact, meets an unmet need, works better for some patients than other treatments relative to other treatments. So comparative effectiveness is the number one thing they've emphasized out of all of the provisions in the law. And right now, what I think a lot of people, including our group, has tried to emphasize is that some more guidance is needed on what constitutes, additional comparative effectiveness value, how that translates into a higher expected maximum fair price for the drugs that are subject to negotiation. And we also think there's some things that CMS could do to make it easier for organizations to develop that evidence. For example, CMS could design coverage in the early years for a drug in a way that encourages its development, could support data sharing around tracking patients, could view this as part of their quality improvement initiatives, where on the healthcare payment side, the healthcare delivery payment side, they're trying to move to payments that are more linked to outcomes that matter to people, including patient-reported outcomes, reducing costly complications and the like. But Patty, I would emphasize that we're still in the early days of implementation. I expect CMS is going to take further steps to describe how they're going to make it easier to develop real world evidence that can count, and what they're going to do to support it in the months ahead.
Mm-hmm. And do you expect them to give the specificity that industry and policymakers need?
Well, I think government never gives you the specificity you want. FDA has a much longer history and a lot more resources to go into developing guidances about new product areas and about endpoints and things like that. I do think we're going to see more steps like that from CMS, and they've made some recent announcements about programs whereby manufacturers can come in and get some more help from CMS, but it's probably never going to be as much as people would like. And I think that's one more reason that people should view the IRA implementation as a stepwise process. If I was at CMS right now, I would focus on getting the most important basics right. Can we make sure we don't make a big mistake in the law? Can we exercise enforcement discretion where there's a price that maybe should be higher than the maximum fair price, as well as some that some prices that should be lower than where the MFP might or where the current price might be, and this is going to be something that hopefully will get clearer over time. This is another area where CMS needs more guidance. They had talked before about maybe these negotiations or discussions occurring in secret, and I can understand why that would be important for proprietary information about a drug, like how much it costs to manufacture and so forth. But for information on comparative effectiveness, especially, I mean, that's information and guidelines and examples that we need to get out there so that people can be clearer about what kind of evidence is expected.
What would you advise a pharmaceutical company to be working on right now?
I think, first of all, I advise watching very closely what happens with CMS in the coming weeks and months. So a couple of clear data points coming up, or one is CMS has issued some guidance on how they're going to implement the price negotiation program in its first year. That final guidance is expected a little bit later this summer, maybe as soon as sometime in July. So look at that. There are several lawsuits that have been filed. Those are going to take some months to sort through. There's going to be another round of lawsuits, I'd predict, once CMS has final guidance and starts implementing a process. There'll be lawsuits around whether that was appropriate administrative procedure or not. Those are being filed in a lot of different courts for a number of different claims. So watch those two, and then watch how this goes in its early years of the price negotiation application. And then the second thing I'd encourage organizations to do is think about some of the features of this law that may actually help them out in important ways. For example, the law includes the biggest expansion of Medicare Part D since that program was created back when I was at CMS when we first implemented it. In particular, new strong protection against so-called catastrophic drug expenditures. So any drug expenditures out of pocket over $2,000 in Part D now going to be covered by Medicare. Previously, people had to pay 5% of those costs, which could get to be thousands of dollars for 2% and growing of Medicare beneficiaries. And plans are going to be on the hook for more of that funding now. But the law did not give drug plans any new tools to limit beneficiary access to drugs. So, for example, for cancer drugs, for drugs for behavioral conditions, for drugs for immunologic conditions, for a lot of very important drugs in Part D, plans cannot restrict formularies. They have to provide access. And I think on net, this is going to be a positive factor for the returns, the revenues that manufacturers are going to be able to get, and certainly for uptake by beneficiaries. Related to this is another factor. I know many of us supporters of the law were not big fans of Medicare Advantage, the private plans in Medicare, which are now half of all of Medicare. If you think about it, those Medicare Advantage plans are going to be able to do a significantly better job with this expanded Part D benefit than the standalone plans. Why is that? Well, they're already used to working with physician prescribers and networks of prescribers to try to encourage the right use of drugs for the right patients. Right now in Medicare Part D, the benefit is more generous already in terms of what drugs are covered and out-of-pocket payments. And they're going to have more ability to integrate drug coverage, now much more comprehensive drug coverage, with care delivery to do things like prevent diabetes and obesity complications, or maybe manage other serious conditions, cancer, et cetera, better. So I think that's going to mean an even bigger premium advantage and benefit advantage for the Medicare Advantage Part D plans and the manufacturers who work with them relative to traditional Medicare. So that's some new opportunities and some new reasons, because the plans are going to be more on the hooks, or the manufacturers, for these high cost drugs, for the manufacturers to work with, find constructive ways to work with drug plans to use drugs effectively. That maybe another place, where the more for better real world evidence would come into play.
So does it make sense, based on what you've just said, that industry could look and compare drug usage and in Medicare Advantage and compare it to general Medicare to get some insight into what this might look like going down the pike here?
Yeah, I mean, we're already seeing in Medicare Advantage kind of lower out-of-pocket costs for some
Mhm,
drugs that are helpful for managing chronic conditions, more generous drug coverage at a lower premium, as I mentioned.
mhm.
And I think what maybe is underutilized is efforts by manufacturers to help the drug plans and their PBMs and the prescribers they're working with to adopt better models of care, where the drugs and more of them, going back to the point where I started, are usable in conditions that can be diagnosed earlier and treated more effectively, whether it's, blood pressure, lipid disorders, diabetes, prediabetes, et cetera. But I think it means finding ways to show that the drugs being used in particular types of Medicare beneficiaries really are making a difference for
Yeah.
their outcomes, for controlling the chronic diseases, for preventing the costly complications. Again, the drug coverage is now more generous, so there are more reasons to do that, and there are going to be more and more people enrolled in Medicare Advantage because I think they're going to be attracted to the lower premiums and the more generous coverage that's going to be possible in this new expanded version of Part D.
How important is the patient perspective in this whole process? I just finished an interview with Dr. Peter Newman, and he alluded to the increasing value of the patient perspective in demonstrating the comparative effectiveness. What do you see happening in here?
Yeah, I hope that works out. I mean, that would certainly go along with the theme CMS has been emphasizing of comparative effectiveness, reflecting patient perspectives on the outcomes that are important for them and additional benefits that a drug can provide versus the therapeutic alternatives. I would feel better if we were further along than we are in routinely capturing and studying
Mhm.
those patient perspectives. I guess back to the topic that we talked about earlier of, it seems like a great opportunity here for CMS to maybe work with FDA as well as patient groups on clarifying, what kinds of patient-reported outcomes they'd like to see. FDA has had for a number of years a patient-focused drug development program that put emphasis on outcomes that matter to patients. So now we've got maybe similar needs and opportunities here. And I'd also like to see, back to one of the topics we started with at the beginning of this, is can we do more to pay for better outcomes for patients in the Medicare program? So one of
Mhm.
Medicare's top overall priorities is to move away from just traditional fee-for-service patients, and as they've put it, give everyone in Medicare access to coordinated longitudinal care, and whether you call it accountable care, an ACO, or something like that, but where your primary care provider group and the other physicians and health systems they're working with are paid, at least in part, based on getting a better patient experience and getting better patient outcomes. Well,
Mhm.
that seems like it could really be synergistic with some of the real world evidence and some of this CMS policy emphasis on supporting drugs that and use of drugs that really does make a difference for the outcomes that matter to patients.
Lately, the news has been filled with pharma, the trade association that represents the pharmaceutical industry, as well as individual pharmaceutical companies like Merck and Bristol Myers, as well as the U.S. Chamber of Commerce, have engaged in bringing some class action suits against the IRA and against constitutional and fiduciary concerns that they have.
Yeah.
What do you see as the impact that these suits may have on the rollout of the IRA and its implementation?
Well, they're definitely going to be part of the implementation process for, I think, at least a few years to come, maybe longer, as these multiple challenges work their way through the courts. And I wouldn't be surprised if some of them, if there are, in some areas where there might be differences in views across judges, eventually make it to the Supreme Court, and that could be a little while. The challenges that you're seeing now, as you said, are constitutional. Some of them are around free speech. I'm not sure those are really going to go anywhere. I mean, the companies can still, for the most part, say what they want. As I mentioned before, there was a CMS proposal saying a company couldn't release their own documents on their negotiation. I don't think that's actually going to stick. I don't think that's the best policy for CMS to follow. But by the same token, just because the law calls this a fair price doesn't mean you have to believe it, and it doesn't mean you can't say that you disagree. So I'm not sure that particular challenge is really going to work. The ones that seem like they might have a better chance are ones related to takings and ones related to due process. And this is like the Fifth Amendment, the Eighth Amendment. I'm not the lawyer, but having talked with a lot of them, this basically amounts to your view on whether the penalty or the hammer that CMS is allowed to apply in these negotiations, which gets to be a large part or all of your revenues in the United States, at least from the Medicare program, if you're a drug manufacturer, is too big. Is that an unfair taking? And on the side of supporters of the law, it's like, well, you don't have to participate in this program. As well, on the flip side, well, you kind of do if you're going to be in the U.S. market at all. And you may remember back with the Affordable Care Act, there was a provision for Medicaid, which essentially said that you state, if you're going to participate in the Medicaid program at all, you have to in an expanded Medicaid program to adults up to 135% of poverty. And the Supreme Court, that went to the Supreme Court, and Judge Roberts led a decision in that case that didn't eliminate the law, but it eliminated the ability of CMS to use that leverage point to get at that particular aspect of the law. So I think people are putting odds in at different levels, but I think that's the kind of complaint that's worth watching, and we'll see how it plays out. And then there will be another round of litigation, not just these constitutional challenges, once CMS starts actually implementing the law and has an administrative process around negotiation where people will find fault with that. CMS got a lot of legislative flexibility to not follow usual notice and comment rulemaking. So the debates there will be fought out in court over whether CMS was doing enough under the law, or whether it's cut the administrative process corners too much. So watch for those legal challenges in the next year or two as well.
Dr. Rochelle Walensky will depart the CDC on June 30th of this year, and your colleague and friend, Dr. Mandy Cohen, has been appointed as her replacement. Dr. Cohen is a physician and a highly respected public health professional who worked at the state level of HHS, and as the chief operating officer of CMS, she helped lead North Carolina successfully through the COVID-19 pandemic. And so most certainly she is highly qualified. What are 3 issues do you believe the CDC needs to get right to regain the trust of the American public?
Well, that's a great question. And I think that is number one for CDC right now, is regaining broad public trust by demonstrating that coming out of COVID, played a critical role in COVID, but coming out of COVID, it can do more to address the public health challenges facing the nation. This is a very challenging time for CDC to do it. There have been, some proposals for giving CDC more resources, more authorities. There's just not consensus out there that could enable that to happen. So Dr. Cohen's going to have to work under the current CDC authorities and current resources to find a way forward. But Patty, I can't think of anybody who would be better in this job than Mandy Cohen right now. In North Carolina, she was able to implement a number of steps, and work very closely with the state at Duke-Margolis on many of them to enable public health and healthcare to work better together. For example, sharing data so we could focus efforts on informing people about their vaccine options and helping make sure they had access, also for tests and treatments as those became available. She collaborated closely with researchers, some of my fellow faculty members and staff members at Duke and Duke-Margolis on issues related to school safety. And North Carolina was one of the states that reopened schools very early compared to much of the other countries, essentially when the school year started in the fall of 2020, with some steps around testing and masking that had some controversies, but that the main effect of getting kids back into school, despite the challenges we're working through with COVID. And I think she's going to bring that same approach of being able to work across the aisle, finding ways for public health to partner with healthcare, with business, with local community leaders when she gets to CDC. And so I would put at the top of her list, number one might be how we work together better in the next public health emergency. We have the technologies now, the medical technologies, so that rapid access to diagnostic tests to figure out what's going on and contain it, and then treatments, both off-the-shelf treatments that work because we know what kind of bug this is, and as well as synthetic treatments like monoclonal antibodies. Those can come along quickly, and vaccines too, but it's going to take a new way of public health working with healthcare to take advantage of that and enable us to contain future outbreaks without restrictive public health measures, and with much better information that we can get from frontline healthcare providers to support it. Second, I think there's some opportunities around many other chronic diseases where healthcare and public health could work together better. We have early diagnostic tests now and good, if not curative, treatments available for everything from hepatitis C and other infectious diseases, flu, et cetera, to chronic conditions like diabetes and pre-diabetes. And then I think third, around trust, we've got people in this country are getting their information they trust from a lot of different sources. One thing that many Americans have in common is that they have a health professional, a physician, a nurse practitioner, a pharmacist, a clinician that they rely on. And instead of public health maybe focusing so much on having press conferences, maybe having public health leaders work more closely with frontline trusted healthcare professionals out in the community, making clear, what do we know now? What do we not know about both public health threats and, just chronic diseases, vaccines, treatments? I think there are a lot of opportunities there, but I do really think Mandy Cohen is the right person at the right time, a very tough time, an important time for the CDC.
I am so incredibly excited about her moving into it and living in the state of Florida. The idea of public trust and working collaboratively with the health professionals on the front line sounds like a pipe dream, but one that I would like to sign up and see it in effect.
Yeah. Well, it should be possible. I mean, we've got better electronic data systems in healthcare. And you think about where people do get their trusted information. We just need to make it easier for people to connect to their clinician, make it easier for clinicians to get the right up-to-date information on new drugs, on new public health threats, et cetera. So I'm pretty hopeful we can do more by bringing these traditionally separate approaches more together around, what medical technology can do. This is where we started, right? What medical technology can do, and how all of us can make it easier for Americans to make informed decisions and stay healthier.
We're almost at the top of the hour. Do you have any closing thoughts?
Well, I really appreciate the time we've been able to spend together today. And I know that none of these issues that we talked about today, whether it's the IRA implementation or the future of public health. None of them seem like they have easy solutions. Seems like a very challenging time for the country right now. I would just encourage everybody to remember how much potential we have to work with. The biomedical technologies are better than ever. The arc of history, if you want to call it that, is definitely moving towards earlier diagnosis, more consumer focus and consumer supportive healthcare that you can get at home. My day job with the Duke Margolis Center is really about how do we develop policies at the national, state, and local level to accelerate progress in that direction. But because there is so much potential there, Patti, despite the challenges that we're facing today, I'm very optimistic about the future.
Mm-hmm. I'm really glad to hear that. Thank you, Mark. I
Great to be
appreciate
with you.
it.